Good afternoon. Thank you for inviting me, and to Paul and the team for having us here in this beautiful city. He told me to tell you a 25-year story in 5 minutes, so we argued, and I think I have 18 and a half, but we'll see. So we'll try to go through this efficiently, but let you at least get some ideas of some of the things that went on in the development of this concept. These are my disclosures. This history obviously begins long before collagenase with Dupuytren's and John Hunter. The picture there of Dupuytren's statue in front of the Hotel Dieu shows the French medical students dressing up Dupuytren's, which apparently is something they do every spring. I was trying to get a nice picture of them, but it wasn't available. Collagenase was known since the investigations of gas gangrene by this German Marshman way back in 1937. Ines Mandel, who was the first woman PhD to be graduated from the Polytech Institute of Brooklyn in the United States in 1949, isolated and characterized collagenase in 1953. And then in 1957, what was then called the AB Corporation licensed collagenase for the debridement of burns, and another company helped them sell it. As you see in the map, this company was located on Long Island, close by us. I came into the picture after finishing my hand fellowship with Dr. Carroll at Columbia University in New York City and moved on to Stony Brook, where I've been ever since. When I first got there, my chairman and boss was Dr. Roger D., who was an immigrant Englishman. And Roger said, "Of course, Laura, you have to discuss Dupuytren's disease. All hand surgeons do that." And I said, "Well, Dr. McFarland has just written a paper about myofibroblasts and Dupuytren's disease, so everything in Dupuytren's disease is done. You don't really have to investigate it anymore." And he insisted that I had to do the surgery and the teaching and the research, and my research would be Dupuytren's disease. So I guess Roger really got me into this. Shortly after I arrived, Marie Badalmente joined our faculty as a PhD in cell biology, and I thought, there's someone who can help me, given that I'm basically a clinician. In the beginning, we did lots of studies, like you saw this morning, about the basic science of Dupuytren's disease. One of our first studies was looking at ATPase and the myofibroblasts, and we brought the films to show McFarland at a meeting in the States, and he invited us to this colloquium in 1989, and that really gave us a lot of encouragement. We met him, we met Gus McGrather, we met Houston, we met Stack, lots of people who had spent their lives working on this, who enthusiastically embraced us and taught us a lot about the disease. So clearly this work is on the shoulders of many other giants. Here's Graham Stack's book, McFarland's book with him and Gus, the work of Raul Tubiana. In 1987, I had the privilege of being the Bunnell Traveling Fellow. One of my lectures was at Oxford, and there George Merrill was a registrar, I believe, at that time. He was an Australian. He took up some of my discussions of what I then called the Krebs cycle of Dupuytren's and later published this diagram, a lot of which I think relates to what you saw earlier in some of the basic science studies we've seen in this meeting. The work in collagenase started in 1990. It was the development of a first-in-category drug and a new therapeutic alternative for Dupuytren's contracture. This started when a man named Tom Wegman actually talked to the head of my blood bank, who said, "Larry, you have to meet this guy. He's got this compound called collagenase, and you should use it with your nerve research." Because at that time, Dr. Badalmente and I were doing a considerable amount of nerve research, and their thought in bringing this to us was we could control the amount of fibrosis around a nerve repair with collagenase. And I said, that's all well and good, but if you put a little too much, the nerve repair is going to fall apart. I am not so sure I want to get involved with that. But we have this other disorder that we deal with in hand surgery called Dupuytren's disease, where basically getting rid of the scar is the goal. So maybe we should try it there first. So we looked at how difficult it was to do surgery. It was painful, a lot of work lost, complications that clearly happened, recurrence happened, etc. So the idea was, could we develop a minimally invasive thing with an injectable substance that would help dissolve and rupture the cord, and collagenase seemed to be an alternative. The idea seemed reasonable. This had been around for a long time now. The FDA had actually approved this for the use in the burn salve debridement, which is a key important point in the development of drug in America for use in humans. if a compound has not been used in humans and approved by the FDA, you have to first show in 3 species toxicology studies, which way back then cost $3 million, that this isn't toxic, and et cetera, et cetera, et cetera. So bringing a chemical to use in a clinical arena is very complex, and we sort of were able to jump ahead because of this simple little burn use. We had to make sure that it didn't damage tendons, nerves, et cetera. There was some data from Scandinavia that showed collagenase being dripped on neurovascular bundles without harm, but the FDA said, of course, you have to do more work. And of course, about this time, my personal life in the Department of Orthopedics at Stony Brook became crazy, to say the least. One morning, we had a meeting about the difficulties in the department. I went and saw my patient in the afternoon. The dean said, my chair had stepped down, and by the way, you're the chair. Please fix all the problems. And as you see, the 3-legged stool became 4 legs, and the stool was tipping over. And I was then acting chair for 2 years, and it really made me feel good when they said, yes, you'll be the real chair, but it was on April Fool's Day. So I figured they really know what I'm getting into. So to go forward with the FDA in humans, we needed an IND. And we obtained that at Stony Brook, and that was the intellectual property of Stony Brook, if you will, and we sponsored the studies. Also, Marie worked hard, and I helped. We got orphan drug status for the compound at that time, which was very important because, number one, it would give 7 years of exclusivity to the use of this if it became a product. But number two, it gave us a chance to get FDA grants. And most of this early work on the Dupuytrens and Collagenase was supported with this type of grant. The company, the BTC company, they had a patent, but except for the drug and a little bit of help with the lab technician salary, the rest of this work was done by grants that we obtained from the FDA and other sources. The first work was then to take the cords out of patients at fasciectomy and bring them to the lab, incubate them with a little bit of collagenase, and the next morning put them in an instrom, grab the cord from both sides, and see how much force it would take to pull them apart. And what we found in this study, this referenced there in 1996, is you could pull the cord apart with less force than it takes than you can do with your own fingers. In other words, if you push your fingers against a force calculator, your extension power is more force than it took to pull these apart. So we said, that's pretty good, it should work. And now can we do it in humans? And of course, the FDA said, no, not yet. So we ended up with this rat tail study where we showed that we could put the collagenase into the tendon of a rat tail without hurting the neurovascular structures or having the tail necrose or fall off or anything. So then finally they said, all right, you can go ahead and start doing patients. So the first study was using about 1/20th of the current dose. Back then, all doses were in units. We're using about 500 units, somewhere in that range, 600 units. The current dose is more like 10,000 units. So we did a number of patients, and none of them worked. I mean, their hands didn't do anything. So I was talking to Marie. I said, look, it's time to go back to nerve research. We're wasting our time here. Marie is an American, but is of Sicilian background, you know, and in America, the Sicilian Italian population has a certain reputation for toughness. And so, you know, we have to go forward. So she conned the FDA into allowing us to do a dose escalation curve where we were to double the dose and either get effect or side effects. And if we got side effects, obviously we had to stop. So one of the very first patients came in, he said, Doc, it didn't work, see? And I went to shake his hand, and as I did, the cord popped, and we said, this might be a good thing. So then we finished that study, and we went on to the phase 2 trials, these 29 patients, and finally then 89, 99, another placebo study. Again, the first studies were open label. We simply used the drug, showed nothing happened to hurt the patient, and then it worked. And this study, we're starting to look at, you know, the difference between a placebo and the drug, and it was still working. Then the FDA intervened yet again and said, that's all nice, but are you sure that the 10,000 units is the minimal dose that you could use to be effective? Their goal is always to use the least drug to get the result that you want. So they made us do the dose level study over again using 2,500 units, 5,000, and 10,000. And pretty much we found that we were correct. The 10,000 unit dose, which is equivalent to about the 0.58 milligram dose that's currently used, was the dose that was most effective in most patients. There were a few that responded to 5,000 units, but the ones, when you got most of them to work, the 10,000 unit was the right dose. Then the team overseeing us at the FDA, basically we were allowed to communicate with them and they'd help us, no, you can't do this, yes, you can do that, blah, blah, blah. We had a good team, we had a good relationship, and they all quit. They went into industry and got better jobs, and the FDA then assigns a new team to you. Well, the team they assigned was the team that had just recently approved Vioxx. You may not know the Vioxx story, but just after they approved it, it was pulled off the market because of cardiac problems. So this team was a little sensitive about approving anything else, including collagenase. This little movie I show just because our fellow back in 2001 and Marie and I did it.
There you go.
That movie has been seen around the world. Most of the people in this room are surgeons. Surgeons pretend they read data, but they really look at movies. So this sort of got us going with people actually paying us a little attention. Next came the issue of commercialization. You can't get from the laboratory to something that's available for all of us unless it's going to become a product, and a product can't become anything unless it's going to make money. So BTC was trying to find the wherewithal to run phase 3 trials, which you probably realize are extraordinarily expensive. They couldn't do it. BTC was a family-owned little tiny company on Long Island with minimal resources, and basically they sold their licensing technology to the company then called Auxilium. The university transferred the I&D to them. Pfizer came into the picture and got permission to use it in Europe. The revised patent was reissued, and we thought we were off, and the FDA said no. Not only does the FDA look at safety and efficacy, they also look at manufacturing. BTC had been manufacturing this collagenase in a small factory in Puerto Rico. The FDA went down there and said, this thing is out of date. It's a 30-year-old factory. We're not going to approve any drug that comes out of these doors. You have to build a new factory. So fortunately, Auxilium had the wherewithal, and they built a factory. I don't know, but I imagine it cost $2 or $3 million, and they finally started to reproduce the drug. Next, we started to try to write the phase 3 trial at Stony Brook. We are then working with Stanford, had 2 places involved, and they said, no, that protocol isn't good enough. You got to do the whole thing over again. We were showing good results. I don't know where that picture went, but basically we're showing it could work. Then the FDA came back and said, that's all well and good. You're ready to move into phase 3 trials, but you got to do more studies, and we're going to come up to your institution and we're going to review every piece of paper you've ever made in the last 10 years. And you see this man who looks like a policeman. The only difference between him and a policeman is he didn't carry a gun, but he looked pretty intense. And he looked at every piece of paper, and finally they said, okay, you can move forward. This was a summary of all the clinical trials that had been done up to that point. A lot of work and time had gone into us. Marie put a ton of work in this. I was the chairman of the department. I'm a clinical surgeon. I do replants. I take call. This was a hobby. This is not my job. And next, with Auxilium's help, we started the CORD study, which was a massive undertaking in 16 sites in the United States and 5 in Australia, and produced the study that ultimately became the basis for telling the FDA where we were at and getting their approval. But of course, nothing is ever simple. Just before that study was about to begin, it was noticed that some of the bottles you see there's a little cake of lyophilized Xiaflex in there, and some looked like a milky glass, that something was wrong. They were still working. You could put the diluent into the glass where the cake wasn't and take out the resultant solution and put it in a patient. It worked, but it didn't look right. The FDA said, nope, everything stops until you prove what's going on. It took 9 months to sort out that a little moisture was leaking into the bottle during manufacturing, and sometimes some of the protein was in solution and then made this milk glass appearance instead of the cake. That finally got solved, and we went on to do the study, and this data, I'm sure you all know, I showed that in 64% of the MPs we could get it straight, and of course the PIPs did okay, but not as well. Some people ask, why was there any result in the placebo group? And the answer there probably is we gave somebody drug when we thought we gave them placebo, quite frankly. That study became the basis of the article that went into the New England Journal in 2009. It was a wonderful thing to participate in. You know, deans of medical schools don't really think that surgeons can write, and they don't count any surgical journal. So when I showed him this, he's like, really, you can do right? That's pretty nice. Later, we were given the honor of the Clinical Research Award from the American Academy of Orthopedic Surgeons. Then in September, the FDA convened a group to look at all the data from all the studies and decided whether they would recommend approval or not. That group had no one in it who had ever done any studies, and also I think had some lay people as well as scientists. They finally voted, after review of all the data, 12-0, that they would recommend, that's the key word, recommend approval of XIAFLEX. The FDA then takes that information and they analyze it with their august executive group, and finally in February 2010, they said, okay, we approve it. The clinic staff made Maria and I this lovely cake you see here. On the bar graph you see over there, you see in 2010, there were only 6 compounds that were approved by the FDA to become drugs. The red bars are all those organic compounds that get considered to be drugs. So this was quite an extraordinary accomplishment. We were one of 6 that year that actually got approved to be used in humans. And I thought, this is great. I'm going to get to use it on my patients, and I won't have to follow all those research protocols. Wrong. So the technique was devised. The bottle became pretty with a label on it. We decided we would run a nice symposium like this about Dupuytren's disease, and God spoke louder. There's this huge volcano in Iceland. Some of my colleagues and friends from Europe never got there. Some got there and almost never got home. But we had a great meeting, as you see here, and I thought, okay, now I'm moving on. And suddenly, I was trying to get this drug for my patients. And the insurance company said, yes, the FDA approved it, but we still consider it experimental. We're not going to pay for it. And so it took from basically May until October before I was really able to treat patients. In October of 2010 at Stony Brook, we had 852 patients waiting to be treated. We had been at this for a decade, and lots of patients came into the study, got treated, told their friends about it, and then everybody wanted this because nobody really wanted surgery. And so we had this huge group of patients that needed treatment. It went into the TV. I don't know how fast this will play, but this is a little story about a doctor who is a family doctor in the Hamptons, which is a little town on the east end of Long Island. And here he is given the XIAFLEX at lunch over a beer to his golf buddy. And then the next day, he's out in the golf, and the buddy's complaining that his fingers are still crooked, and as you see, he gives him a yank, and he fixes it on the golf course. Needless to say, I've never been able to duplicate this particular approach. So next, we've had a lot of commercial partners develop. Pfizer was in it, Actelion for Canada and Australia, now Sobi for the European Union, the AK Pharmaceutical in Japan took it over Japan. I actually met one of their people in Norway, and he said, oh, I want to talk to you about collagenase. And I said, you are Japanese, right? You don't really have that in your country. You're going to lose money. But apparently, the American occupation, whatever, they have Dupuytren's in Japan. And I think, quite frankly, they're indicated in other indications. Frozen shoulder, for instance, is a big problem in Japan, and that's one of the areas that they're interested in. And now, as you know, Auxilium has been bought out by Endo, and there's yet another group of people, which is also part of the story because there's almost no one left that started when we started with this that we know who's on the commercial side of this. And so, you know, you're always talking to a new guy or new lady who has really no clue about what you did or what went on. I do patients by the indications mostly you use. I look for the bowstring part to put the medicine in. Everybody knows the dose. Everybody knows how you put it in. I now use local anesthesia for all manipulations. I do the vast amount of these in my office with an injection on Monday and a manipulation under local anesthesia on Tuesday. Occasionally, if a person has, ASA 4.5, and I'm wondering if I'm crazy for giving them any treatment whatsoever, I take them to my ambulatory surgery center where my anesthesia colleagues don't put them in the OR, but they monitor them and sedate them a little so I feel more safe with those. So I have done some people with pacemakers and stuff, but only under very controlled circumstances. I now do the manipulation in this very careful 4-step manner. And what I've found when I do this is I get pretty good results from the extension procedure, but also I've minimized my skin tears. So at this point, since February 2010, I've treated about 955 patients with Dupuytren disease. It's kind of, be careful what you wish for. Suddenly my office is overwhelmed with these Dupuytren's patients. In this time period, about 467 came and just have a nodule, and I basically observed them. I do nothing. 443 had cords, which I treated with collagenase, and 45, for various reasons you'll see, had surgery. Since the beginning, I've treated 700 patients with collagenase, 257 in research studies, and the 443 since, for a total of about 700. The total group receiving collagenase is, since 2010, is 488 patients, and they represent 91% of the people that I've treated. The surgical case data you see there. Surgeries, you can see I did it when there was a nodule excision only for severe pain or some question like that, a nodule sitting over a trigger finger, some fasciectomies, recurrence, I don't want Xiaflex, etc. Another indication I feel is with split thickness skin grafting. I've done quite a number of people that have previous surgery and recurrence, but if you have damaged skin and you use Xiaflex, you're going to get a tear. And the tear will heal and the finger will be straight, but when the tear heals, the finger is going to recontract. So in those patients, I recommend fasciectomy and skin graft. And sometimes if you need a fasciectomy and a carpal tunnel, it just makes more sense to do both at once. The digit widget I've used a couple of times. This is really a helpful trick for patients that have severe joint contracture with the cord. Here's the fasciectomy breakdown. So here's my experience with the Xiaflex, 611 injections in 443 people. Most of my repeat injections have been for other cords, other hands. Some have been for recurrence, some have been for it didn't get quite as straight as the patient wanted. My other hand surgeons at Stony Brook do this as well. We've done probably over 1,000. In America, the experience, at least in country, looked at by the vials sold, is somewhere over 60,000 people have received this now. The breakdown by age and sex and handedness, et cetera, is pretty much the same it is in any large series of Dupuytren's patients. You'll note that 31% had prior surgery, so I certainly didn't shy away from treating people with difficult presentations. 4% had also had treatment with Xiaflex before. The MP involvement was 81%, PIP involvement 66%. The central cord obviously contracts both most of the time, and that's sort of 50%. I've done some DIP joints. Now, I might stop here just for a second. That's off-label, okay? So in the United States, off-label, as it probably is here in Europe, is a big deal. As a clinician, I can decide legally in the United States to use it off-label, but if I were talking for the company, they'd kill me if I told you that I did this because I'm not supposed to do that. But I'm not talking for any company. I'm just telling you my personal experience. So yes, I've done DIP joints, and I'll show you an example in a minute. I've done a considerable amount of work with combinations of cords, such as a Y cord, central cord, and a natatory cord, central cord with 2 natatory cords. I've done thumbs and some quite complicated ones. The double dosing, I have used it up until just recently in 4% of my patients by splitting a single dose. If you find 2 central cords that are quite little strings, 1 dose can be used and correct both at once. 2 separate full doses I used in the research study, and as you'll hear from other people in this meeting, 2 doses is now FDA approved. It's not off-label. I have used it, and it works nicely. I've also done in studies, and now formally, without being off-label, manipulations at 48 and 96 hours. It's clear that that doesn't matter. Here's a simple case, central cord, where I put the drug.
All right, make a fist, sir.
And here he is 2 weeks
Open.
after.
One more.
Here's a Y cord, 56-year-old male. You see there where the drug is put.
Okay, so there's the
Here's
Y
the extension
cord,
procedure.
Here to the ring finger, natatory to the 5th finger, and we've numbed him up, so we're going to manipulate this. There's the ring finger corrected. Make a fist, sir. Open. Excellent. Relax a minute. Let's see if we can get this natatory cord. There it goes. Make a fist. You okay? Yep. Straighten your hand.
I don't want to take too much of your time. Here's the result at 3 days. Abductor digiti minimi cords can be done easily. You have to be careful with the nerves.
He's got a large nodule
Here's
here
the
in
injection.
abductor digiti quinti
Simply
cord,
put it in the
and
cord,
we're gonna
don't put
stay
it in
away
the
from this
tendon.
flexion crease and inject him.
Here's the manipulation.
There it goes. Nice. Straighten your hand. Make a fist.
And there you see some
Open.
residual PIP
Okay.
contracture because of the stiffness of the joint. Here's a very complex cord. This was done with 1 dose, splitting it up. When you look at the cords, you have to look at the cord thickness. Obviously, a big fat cord takes more drug than a skinny one. Here's the result of that after it was treated. Here's another complicated cord.
No, I know. You
Here,
can
but
feel this,
Yeah.
but that doesn't
That I
hurt
don't
anymore.
feel, no.
Okay,
Don't
good. Make
feel
a fist
anything.
for me.
This lady was so
Okay,
nervous
open.
she couldn't stop
See, you can make
talking.
a fist and it doesn't hurt.
No, it doesn't.
Okay, all right, relax. We're going to do 1 finger at a time here, starting with the ring. You okay? Mm-hmm. All right, with the PIP open. There it goes. And there goes the PIP. And
Look at your finger.
Look at there.
Oh, my God.
Okay, so that's halfway. Okay,
Darn.
you all right?
Yep, no, I'm,
Okay, now the little finger, but keep the PIP bent so in the beginning. And relax
And-
your hand, don't fight me. There it goes.
There it
I
goes.
heard it.
Yeah. Now relax it again. There goes some more. There goes a whole bunch more. Make a fist for me. Open up.
I don't want to
Okay.
waste your time, so we'll move on. Lateral cords for the DIP. In the past, I've done surgery, as you've seen here. Here's one that's causing a very severe DIP contracture, and here's the extension procedure.
PIP and a little bit to the DIP joint, and an abductor digiti quinti cord here, and we're going to manipulate her. So relax your hand, ma'am. Oh, there it goes. Look how easy that does.
I find that the DIP and PIP contractures, particularly when they're virgin non-recurrent, seem to respond very well with very little manipulation.
Do the PIP.
The thumb has been done. There's the targets, and this video shows it straightening out.
Cord and a small commissural cord. He was in.
As I said, the digit widget sometimes helps. And finally, here's a case of 2 central cords, a large nodule. The target you see there transversely in the 5th finger. The injection got rid of the nodule and the cord. And this is just the last couple of videos. Here's the injections.
The cord for the ring finger. Try to stay as still as you can, sir. It'll hurt some. And we'll give
The
this
actual
about
time to
4
do this takes
aliquots.
about 2 minutes to inject and 3 minutes to manipulate on a following day. When you're injecting, it's important to hold the barrel of the syringe. Don't let the needle advance past the cord while you're injecting. And obviously, we use the second dose in the little finger. So we're going to manipulate this gentleman today in the central cord to the ring finger, central cord to the little finger. That's your hand. Make a fist, sir. Open. Okay. Let it go loose. Starting the ring finger. There you go. Straighten your hand. Make a fist. Okay. Relax it. Let it go loose. Now the little finger. There's another one. Make a fist. Open your hand. Open. And here he is at the end. The data shows that this works. We get good results. I certainly have not shied away from doing PIP joints, but they're more difficult. Skin tears do occur. You'll notice in the extension procedure I'm quite gentle. If you're gentle and careful, you can really minimize the skin tears. The whole side effects thing is there. The Coumadin deal, there's a recent paper that shows you can do it without stopping Coumadin. Here's a lady who couldn't stop her Coumadin. Her arm looked really scary, as you see there. 3 weeks later, it looked fine. Recurrence happens. I tell all patients you can't cure this, whether you do surgery, needle, or collagenase. It's a question of what you can do and how you use it. Thank you very much.